This podcast is for education and commentary only. It is not medical or legal advice, and listening does not create a physician-patient or attorney-client relationship. When I discuss lawsuits or court decisions, I'm relying on publicly available records, and I will distinguish allegations from findings. My analysis reflects my opinions about risk, systems, and documentation, not personal judgments about any individual. To protect privacy, I may omit or change identifying details where appropriate. If you need medical or legal advice for your situation, consult a qualified professional. If this is a medical emergency, call 911 or your local emergency number. A woman in her late 60s, active, healthy, recently retired, goes for a walk with her husband. They love the outdoors. They've spent years imagining what retirement would look like: travel, hikes, family time, grandkids. And then, quietly, something starts to change. Not dramatically, not all at once, just off. Weakness, nausea, a little dizziness, the kind of symptoms people explain away until the day they can't. At first, she didn't notice how far the symptoms had progressed. They came on slowly. But then one day, she struggled with basic tasks at home. Simple things she'd never had trouble doing. She made an appointment with her primary care provider. Routine blood work revealed something that immediately raised concern. She was hyponatremic. Her blood sodium was low. She'd also lost some weight, but there was no change in her diet and no intention to lose weight. So now we have a question. Why would a relatively healthy woman develop significant hyponatremia?
Let's pause for a practical explanation, because hyponatremia is one of those lab abnormalities that can sound simple, but rarely is. Sodium is not just salt. Clinically, a low sodium level usually reflects a water balance problem, too much water relative to sodium, more than it reflects not eating enough salt. Your body keeps sodium in a tight range using a network that includes the kidneys, hormones like antidiuretic hormone, or the renin-angiotensin-aldosterone system, and lastly, cortisol, a stress hormone that also affects vascular tone and water handling. When sodium is low, clinicians typically work through a structured differential. At this point in the story, that differential might include medications, especially thiazide diuretics, SSREs, and some anticonvulsants, heart failure, liver disease, or kidney disease, states where the body acts volume depleted, true dehydration or volume loss from vomiting, diarrhea, or poor intake, SIADH, syndrome of inappropriate antidiuretic hormone, hypothyroidism, and adrenal insufficiency. The key point is this: hyponatremia isn't just a diagnosis, it's a clue.
Her primary care doctor sent her to the emergency department. She was admitted with a sodium level of 120. That's a number clinicians take seriously. Symptoms can range from subtle fatigue and nausea to confusion, seizures, and coma, depending on how fast the sodium falls and how low it gets. She was admitted to the hospitalist service, and nephrology was consulted. More testing was obtained, including urine sodium, 70, urine osmolality, 500, those numbers matter. A high urine osmolality suggests the kidneys are concentrating urine, meaning ADH is active. A high urine sodium suggests the kidneys are losing sodium rather than conserving it. She received normal saline in the emergency department, and by the next morning her sodium had improved to 125. After evaluation, she felt significantly better. A repeat sodium later that day was 128. She felt well enough that she was relieved to hear she could go home. Because she had a known history of hypothyroidism, the team checked a TSH to rule out thyroid dysfunction as a contributor. The TSH came back normal, and she was told to continue her usual dose of Synthroid. And then, she went home, feeling better, relieved, but without a clear explanation of why this happened or what to watch for. She had follow-up scheduled with her primary care doctor, but the hospitalization ended with uncertainty. No tidy diagnosis, no clear preventive plan, just a lingering question. Why did her sodium drop so low? And why did it respond so quickly? For about a week, she did well. Then the symptoms returned. This time her husband noticed it first. She wasn't eating, she wasn't herself, and she seemed drained, nauseated, and disengaged from normal activities. Both of them grew frustrated. Was this depression? Was this anxiety? Was it just getting older? She tried to keep up with her usual routine until she couldn't. Eventually, she became so weak that she fell and nearly collapsed. Her husband called 911. He knew something was wrong. She arrived at a different hospital, one that didn't know about her recent admission. She looked sick. She was nauseated, aching all over, and her heart was racing. Her blood pressure was low. In the emergency department, the team moved quickly. They suspected sepsis, a life-threatening, dysregulated response to infection, because she looked like she was in shock. Her vital signs supported the concern. Heart rate, 130. Normal sinus rhythm blood pressure, 88/45. She told staff her blood pressure normally runs low, but this was still concerning. Labs were drawn, and then the sodium result came back, lower than before. Sodium, 116. She received IV fluid boluses, but she didn't respond the way the team expected.
In many hospitals, when sepsis is suspected, teams follow a standardized pathway, often tied to quality measures like the SEP1 sepsis bundle. While specifics vary by institution, the general approach usually includes measuring lactate, drawing blood cultures, starting broad-spectrum antibiotics early, giving aggressive IV fluids when hypotension is present, and escalating quickly if blood pressure doesn't respond. If fluids don't restore perfusion, clinicians add vasopressors. The most common first-line vasopressor is norepinephrine, often known by the brand name Levophed. Levophed works primarily by tightening blood vessels, raising vascular tone to increase mean arterial pressure, and improve blood flow to vital organs. So when she didn't respond adequately to fluids, she was started on Levophed. On paper, it looked like septic shock, but there was still a major problem. They didn't have a source of infection.
A hospitalist evaluated her in the emergency department. It was nearing shift change. She looked ill, like someone in shock. But the story wasn't fitting cleanly. She wasn't known to be frail. She wasn't immunocompromised. Imaging and early evaluation weren't pointing to infection. So the physician did what good clinicians do. They slowed down and asked better questions. She had a history of hypothyroidism. When asked more specifically, she explained she was diagnosed with Hashimoto's thyroiditis years ago and had been stable on the same dose of Synthroid. Her TSH in the emergency department was normal, supporting that her thyroid replacement was adequate. Then the physician noticed patches of skin that were depigmented compared to her baseline tone. The patient confirmed vitiligo. Not painful, not new, just present. And in the physician's mind, those details clicked into place. Hyponatremia, shock-like physiology without a clear infection source. Autoimmune thyroid disease. And vitiligo, another autoimmune condition. The physician had a diagnosis in mind, one that is easy to miss and deadly if you do. I'm sorry, the background music is distracting me. Who the hell chose that music? Do you know what's happening now? This patient likely has a life-threatening condition that many clinicians will only diagnose a handful of times, sometimes only once, in this setting. The physician stepped out and quickly reviewed key references. Because when you suspect this diagnosis, time matters. Then they returned to action. They ordered blood work to be drawn immediately, before treatment, if possible, so the diagnosis could be confirmed. And then they ordered hydrocortisone, 100 milligrams IV now. Brand name, Solu-Cortef. This is a classic emergency dose used when adrenal crisis is suspected. Within hours, she started to improve. Steroids were continued on a schedule, often every 6 hours initially, while she was monitored closely in the ICU. Her hemodynamics stabilized. Her clinical appearance changed, and for the first time in a long time, she felt noticeably better. Imaging didn't show cancer. Workup didn't reveal an infection source. But the endocrine testing, sent on admission, told the story. When the results returned, they confirmed what the physician suspected: primary adrenal insufficiency, Addison's disease. Her cortisol was critically low. Her ACTH was markedly elevated, consistent with the pituitary signaling the adrenal glands to produce cortisol, while the adrenal glands failed to respond. And when clinicians attempted to stimulate the adrenal glands, often with a cosintropin stimulation test, they still did not produce adequate cortisol. This is the physiology of Addison's. The adrenal cortex can't deliver the hormones you need to live, especially cortisol, and often aldosterone as well. Without cortisol, blood vessels lose tone, the body struggles to maintain blood pressure, the stress response collapses, and nausea, fatigue, weakness, and confusion can escalate. Without aldosterone, the kidneys waste sodium and water. Blood volume drops, hyponatremia worsens, and potassium may rise, though not every case presents identically. In many patients, adrenal crisis can mimic septic shock, hypotension, tachycardia, diffuse symptoms, abnormal labs, yet no clear infection. And in her case, the autoimmune history mattered. Narrator, Brian. Her Addison's disease was part of an autoimmune polyglandular syndrome, most consistent with type 2, where autoimmune adrenal insufficiency can occur alongside autoimmune thyroid disease and other autoimmune conditions such as vitiligo. It's uncommon. It's dangerous. And if you don't think of it, you don't diagnose it. Now, let's step back from the story and make the clinical and systems lessons explicit. Michael is going to break down adrenal crisis. What it is, how it hides, and how to document and act in a way that protects patients and reduces preventable harm.
Adrenal crisis is an acute, life-threatening decompensation from severe cortisol deficiency, often with additional mineralocorticoid deficiency when the problem is primary adrenal failure, as it was in this case. At baseline, cortisol supports vascular tone, catecholamine responsiveness, glucose homeostasis, and inflammatory control. During stress, Infection, surgery, trauma, or GI illness, cortisol demand rises. If adrenal reserve is inadequate, compensation fails. In primary adrenal insufficiency, aldosterone deficiency adds a second hit. Sodium wasting, volume depletion, hyperkalemia, and worsening hypotension. That's why these patients can present with a mixed shock picture and not respond the way you expect. The clues are often nonspecific: severe fatigue, nausea and vomiting, abdominal pain, dizziness or syncope, confusion, hypotension, hyponatremia, hyperkalemia, hypoglycemia, sometimes fever, and sometimes hyperpigmentation if the process has been brewing. None of these alone is diagnostic. Together, they can still be mistaken for sepsis, gastroenteritis, medication effects, psychiatric disease, or just dehydration. This is where cognitive error creeps in. We anchor on the first plausible diagnosis and never reopen the differential when the patient fails to respond as expected. In many adrenal crisis harm narratives, the issue isn't that no one ever thought of it, it's that no one acted on it quickly enough. Let's make this practical. In undifferentiated hypotension or shock, especially with hyponatremia, hyperkalemia, persistent vomiting, unexplained weakness, or a history of steroid exposure, adrenal crisis should move up your list fast. You can and should obtain immediate labs if feasible: serum cortisol, plasma ACTH, a basic metabolic panel, and glucose. Renin and aldosterone can be added later for classification. But in unstable patients, the message is consistent across emergency practice: do not delay treatment for confirmatory testing, because delayed steroid rescue is where preventable harm lives. There's a documentation phrase I like: adrenal crisis considered due to refractory hypotension plus compatible electrolyte and symptom pattern, empiric stress dose hydrocortisone given emergently while confirmatory studies pending. That sentence tells the next clinician, and if needed a reviewer years later, that your timing was intentional and aligned with the physiology. Emergency management is straightforward in concept and high stakes in execution. Here is the immediate protocol. First, give hydrocortisone 100 milligrams IV or IM immediately. Next, aggressive isotonic fluid resuscitation, typically normal saline. Add dextrose when indicated by glucose status. Then, continue hydrocortisone at crisis dosing, commonly 200 milligrams over 24 hours, either as a continuous infusion or 50 milligrams IV every 6 hours, until hemodynamically stable. Correct hypoglycemia and address electrolyte abnormalities. Evaluate and treat the precipitating cause: infection, GI losses, abrupt steroid withdrawal, intercurrent illness, procedural stress, or other triggers. Finally, transition to oral replacement once stable. In suspected adrenal crisis, this is not optional early treatment. This is life-saving emergency care. Two common misses: giving fluids but no steroid, or giving one steroid dose but failing to sustain crisis-level dosing for the next 24 hours. That second problem is subtle. The patient looks better briefly, then drifts backward physiologically. Build the continuation orders early. Once the patient is stabilized, you complete the diagnostic architecture. For primary adrenal insufficiency, the typical pathway includes morning cortisol and ACTH as key early markers, 250 micrograms cosintropin stimulation testing when clinically appropriate, renin and aldosterone assessment for mineralocorticoid status, and 21-hydroxylase antibodies when autoimmune adrenalitis is suspected. Primary adrenal insufficiency is adrenal level failure. ACTH is generally elevated, and mineralocorticoid deficiency is often present. Secondary or tertiary adrenal insufficiency may have different electrolyte patterns and usually preserves aldosterone function. Etiology also matters. In many adult settings, autoimmune adrenalitis is a common cause of Addison's disease, but the differential still includes infection, hemorrhage, infiltrative disease, metastasis, and iatrogenic pathways. One practical pearl: random cortisol values, especially drawn outside morning timing or during evolving critical illness, can mislead. Don't overinterpret a single number divorced from context. Pair physiology with timing, ACTH, dynamic testing when feasible, and the overall clinical picture.
After stabilization, chronic management is where recurrence prevention happens. A typical outpatient replacement framework for primary adrenal insufficiency includes hydrocortisone in divided physiologic doses, individualized to the patient, and fludrocortisone for mineralocorticoid replacement when indicated. But prescriptions alone are not enough. High-value safety steps include written sick day dosing rules, explicit triggers for escalation, access to emergency injectable glucocorticoids with training, medical alert identification, an emergency steroid card, and clear teach-back documentation that the patient and family understand when and how to act. Because the next crisis is often not from rare biology. It's from common systems failure. No plan, no access, no education, and no reinforcement.
I want to emphasize that patient-educated is weak documentation. Better is specific, reviewed sick day doubling/tripling protocol, vomiting contingency, emergency injection technique, and return precautions. Patient and family performed teach-back accurately.
Delayed diagnosis in adrenal insufficiency has been repeatedly described in cohort and survey literature. The reasons are predictable. 1. Symptoms are nonspecific and often chronic. Fatigue, GI complaints, weakness, weight change, mood symptoms. 2. Intermittent compensation masks severity. Patients can look not that sick until stress tips them into collapse. 3. Fragmented care. Multiple urgent visits without longitudinal synthesis. 4. Premature closure. Once a plausible label is applied, contradictory data gets discounted. 5. Misuse of labs. Overconfidence in random cortisol, missing ACTH pairing, delayed dynamic testing logic. 6. Failure to reevaluate refractory hypotension when fluids, vasopressors, and broad bundles don't fit. Endocrine causes must re-enter the frame. Hyponatremia makes the picture trickier. It has a broad differential. If adrenal insufficiency isn't explicitly considered, the workup can drift toward SIADH, medications, or volume disorders without endocrine closure.
Exactly. Hyponatremia pathways are useful, but they're only safe when they force you to exclude adrenal insufficiency and hypothyroidism systematically. If that step is skipped, the algorithm gives false confidence.
When Addison's disease appears alongside autoimmune thyroid disease, and sometimes alongside type 1 diabetes, vitiligo, pernicious anemia, celiac disease, or gonadal failure, think autoimmune polyglandular syndrome type 2, or APS2. A PS2 often unfolds over years. One autoimmune endocrine condition appears first, another develops later, and the clustering may not be recognized until a crisis forces the issue. That creates missed opportunities both before and after diagnosis. In autoimmune Addison's disease, screen for other endocrine autoimmunity. And in a patient with autoimmune thyroid disease or type 1 diabetes who develops unexplained fatigue, hypotension, or electrolyte abnormalities, screen for adrenal disease early. This isn't over-testing, it's pattern recognition.
One framing I use with trainees: when a patient has one organ-specific autoimmune disease, don't ask, could there be another? Ask, which one is most likely next, and how would I catch it early?
Let's talk medico-legal precision. In adrenal crisis-related malpractice claims, common allegations may include failure to include adrenal insufficiency in the differential, delay in stress dose steroid administration, inadequate response to refractory hypotension with key lab patterns, and discharge without adequate crisis prevention education. A critical distinction. An allegation is not a finding. Courts and expert reviewers evaluate whether care met the standard in the context of the available information, timeline, and documented reasoning. Your strongest risk reduction strategy is not defensive medicine. It's visible clinical reasoning, timely action, and clear communication.
If you considered the diagnosis, acted in real time, and documented why, the record reads very differently from a chart where adrenal crisis only appears in hindsight.
Here's a high-yield, shift-ready checklist. I'm going to keep it tight. A. Recognition checklist for the acute care setting. Refractory hypotension or shock plus nonspecific constitutional or GI symptoms. Hyponatremia, hyperkalemia, hypoglycemia, eosinophilia, or unexplained volume depletion. History of steroid exposure, autoimmune disease, recent infection, surgery, or abrupt medication changes. If yes to any of the above, elevate adrenal crisis concern immediately. B. Immediate action checklist. Draw cortisol, ACTH, in critical labs if it does not delay treatment. Give hydrocortisone 100 mg IV or IM immediately. Start aggressive isotonic fluids. Correct glucose and electrolytes. Continue hydrocortisone at crisis dosing, commonly 200 mg over 24 hours until stable. Search for and treat the precipitating trigger. C. Stabilization and diagnostic checklist. Confirm adrenal insufficiency pathway when feasible. AM cortisol/ACTH, dynamic testing. Differentiate primary versus central cause. Evaluate autoimmune etiology, including 21-hydroxylase antibodies when indicated. Assess mineralocorticoid axis for replacement planning. D. APS-2 screening checklist. In confirmed autoimmune Addisons, assess for autoimmune thyroid disease, type 1 diabetes, and associated autoimmune conditions guided by history and exam. In patients with an existing autoimmune endocrinopathy and new unexplained constitutional collapse or electrolyte disturbance, screen for adrenal disease early. E. Discharge and outpatient safety checklist. Clear maintenance dosing versus stress dosing plan. Fludrocortisone plan when indicated. Sick day rules provided in writing. Emergency injection kit prescribed and taught. Medical alert and emergency steroid card counseling documented. Endocrinology follow-up arranged. Return precautions and teach-back completed.
Here are charting elements that reduce ambiguity and improve continuity. 1. Differential visibility. Adrenal crisis included in differential due to hypotension, GI symptoms, and electrolyte pattern. 2. Treatment timing clarity. Empiric stress dose hydrocortisone administered prior to confirmatory testing due to hemodynamic instability. 3. Response tracking. Post-steroid and fluid response documented with serial hemodynamics and mental status changes. 4. Diagnostic plan. Plan for adrenal axis confirmation and etiology differentiation after stabilization. 5. Patient education specificity. Sick day dosing, emergency injection, and return precautions reviewed with teach-back. 6. Handoff reliability. Pending labs and endocrine follow-up needs explicitly communicated at transitions of care.
That's the kind of documentation that supports safer care and clearer accountability. Before we close, let's return to our patient. She leaves the hospital with a diagnosis, medications, and follow-up. But the first month is where preventable readmissions happen. Why? Because she might catch a GI virus and can't keep oral steroids down. Because she forgets when to double or triple dosing. Because family doesn't recognize early warning signs. because the next emergency team doesn't know she has adrenal insufficiency. So the first 30 days should be treated like a second phase of acute care. A strong 30-day plan includes medication reconciliation that explicitly separates maintenance dosing from stress dosing. A written, if vomiting, inject and seek emergency care plan. Confirmation that emergency hydrocortisone is physically in hand. Endocrinology follow-up with contingency planning. And communication back to primary care about APS2 screening trajectory. For APS2 specifically, consider documenting a staged surveillance strategy rather than one-time testing only. Autoimmune endocrinopathies can emerge sequentially. Today's normal result doesn't guarantee next year's normal physiology.
From a risk lens, this is where closed-loop communication matters. If I hand off adrenal crisis resolved without a prevention architecture, I've only solved half the problem. A practical handoff line: high relapse risk if intercurrent illness occurs before patient masters sick day protocol. Emergency steroid readiness and teach-back confirmed today. Reassess at first follow-up. That prompts the next clinician to continue prevention work, not assume it's already complete.
Adrenal crisis teaches a brutal lesson. Rare doesn't mean optional. Addison's disease can hide in plain sight for months, then declare itself in hours. If we wait for perfect certainty before acting, we lose time patients don't have. If we treat early, think systemically, and screen for autoimmune clustering like APS2, we can prevent collapse, reduce recurrence, and improve outcomes that matter.
On your next shift, when a patient's hypotension and hyponatremia don't quite fit the first story, pause and ask the endocrine question early. That one decision can change everything.
In our next episode, we will shift gears and focus on physician documentation. It's sometimes called note bloat, and it causes more patient harm than we may realize. This content is educational and is not medical or legal advice, and it does not create a professional relationship. For personal guidance, consult your own clinician or attorney. If this is a medical emergency, call 911 or your local emergency number.